And it's time now to dive into the core theme of our conference. I would like to, at the beginning, just encourage you to use this space of this beautiful Colegio Mexico and to do and ask questions. We designed the program to be a forum, a discussion. So please, just when we will open the panel, don't hesitate to interact with our panelists and ask questions. Before introducing our guests for the opening lecture, I would like to take a few minutes. We will be a little bit late today, but we are in Spain, so probably that's a culture. So let me explain why we chose this year's theme, Enhancing Patient Safety Through Digital Innovation, the missing links. Over the last year, the technology's potential to transform healthcare system has become increasingly undeniable, especially from the patient perspective. Among the others, telemedicine, artificial intelligence, virtual reality, and many other systems have the ability to improve or have the potential to improve efficiency and patient safety. So if digital health and available solutions hold so many promises, why are tangible results still a long way off? Why over 1 in 10 patients continue to be harmed during the care? Why from this harm, 50% is still possible to be prevented? So obviously, there must be some missing links that need to be identified and addressed. And in fact, when we were planning this conference, we realized that we had some ideas about these links. So we decided together, again, with our Spanish partners, to publish an article in the European Journal of Patient Safety and Risk Management, entitled, or holding the same title as the name of our conference. So summarizing the article in just a few minutes wouldn't do it justice, so I encourage you to explore it by yourself. Everyone received a copy of the article in the folder, and thanks to our collaboration with Peter Walsh, that I can't see just now in the second, and the journal, this article has been made openly. It's a free access, so you can also share it with your colleagues and through your networks. So as we were searching for someone who would be able to explain what we were trying to put in this article, thanks to our network, we were connected with William Monaghan, who is the Group Chief Digital Information Officer at University Hospitals of Leicester NHS Trust and University Hospitals of Northamptonshire. Yeah, okay, thank you. So after a few lines and few discussions with William, we actually understood that everything what we tried to develop in the article was William's everyday work and reality. And that's why we thought, okay, William must be our keynote speaker. So let me welcome William, and let's see about his ideas about the missing links to improve patient safety through digital innovation.
Hola a todos. Es un gran honor estar aquí en Madrid hablando con ustedes. I'm now going to revert to the very British stereotype of speaking slowly in English loudly and expecting everybody to understand me. So let me give you some background. So my name's Will Monaghan. I didn't realize until today how difficult it is for people to say the organizations that I work with. It's one of those English terms that tricks everybody up. So I want you to imagine in your mind that you are pronouncing University Hospitals of Leicester. Very good. Leicester and Northamptonshire. It is one of the most tricky English words to say, even for our American colleagues. But we are two major hospital groups. We have over 3,000 inpatient beds, 2.4 billion of taxpayers' money is spent delivering healthcare in those two organizations. We have over 30,000 staff, and we serve 2 million of population. And I'm here to talk today a little bit about digital and patient safety. But before I do, I think it's worth understanding a little bit about the journey that the NHS has been on in this regard. I think the better we understand our history, the better placed we are to think about where our future success might lie. So the NHS is the world's largest publicly funded health service. I say the NHS, but now having heard from colleagues in Spain, I should say an NHS, or our NHS. Employing over 1.4 million staff. On there, you've got the statistics of a day in the life of the NHS. And we've spent over 20 years trying to digitize the NHS. We've had the National Programme for IT at £12 billion, one of the most expensive IT transformation projects in history, largely regarded as the biggest failure in transformation anywhere in the world. We've had care.data. It was about how we transform the use of patient data for public good. It was abandoned at significant cost on the back of losing public trust in its use. And we've had varying attempts at this, all with limited success to date. We've somehow made it harder to be a clinician in the NHS rather than easier. Think about that. Despite all of our investment, all of our innovation, all of our good intentions, we've created a system where skilled healthcare professionals spend more time serving technology than technology spends serving them. It's quite an achievement and not one we can be proud of. So let me paint you a picture of the current reality on the ground today. Across healthcare, and I'm sure it's also likely the case not just in the NHS, but across Europe, we have a fundamental problem, a massive credibility gap between digital teams and frontline clinical staff. And in that gap exists space for patient safety to continue to be compromised. In our maternity unit, midwives are documenting the same information in 3 different systems because each pathway requires slightly different versions of the same data. In our intensive care unit, we deliver ECMO. It's the way in which patients that have without heart and lung function are able to be kept alive while they recover. We're one of 3 centres in the UK that do it. The absolute kind of cutting edge of clinical technology anywhere in the NHS. And we expect our nurses to manually copy down vital signs from monitors onto paper to be uploaded into systems later. And the impact of these failures to date? Well, studies have shown that clinicians now spend a significant amount of their time at work administering rather than caring. Think about that. In an age of unprecedented technological capability, we've created a system where, according to various studies, nurses spend 35% of their time on documentation rather than on patient care. We did a very small study in an organization I was in previously looking at junior doctors and doctors in training and the amount of time they spent on screen and on the phone compared to the amount of time they spent with patients and learning from senior clinicians. They spent over twice the time on screen and on the phone compared to learning and being with patients. And the safety impact of these things is staggering. Our clinical teams tell me about the sense of frustration at the mismatch between the speed that they think and the speed that they can act. Missing crucial information about the care of patients because it's buried in multiple systems. feeling professionally compromised because they spend more time on data entry than they do on patient care, and developing workarounds just to get through their day, which in turn creates new safety risks and leaves them feeling anxious because they haven't followed the protocol exactly and feel exposed by doing so. So why bother with digital transformation at all then? If you had a time traveler and you were to bring them from an outpatient clinic 100 years ago and deposit them in an outpatient clinic in the NHS, they would largely see it as the same thing. Maybe a few more screens, but the process is largely the same. It reminds me of the old joke about outpatients, which I am sure you have all heard, which is, why did the patient come to the outpatient clinic? To remind the doctor to look at the notes. So why not stay as we are then? Well, my answer is, we can't if we care about safety, and we can't if we care about what it feels like to deliver care in our services. So we can't go back. We must therefore go forward, but in the right way. The missing links between digital innovation and patient safety aren't technological, because they're human. You'll see from the slide here the number of times where we've managed to implement systems that haven't worked and the impact that's had on others. The UK government has made a lot of mistakes, but one of the things that it got right was it redesigned fundamentally the way citizens interact with it through the development of a system called gov.uk. No longer did every single department have its own website and its own way of interacting with citizens, but everything was standardized onto a single platform. Now, I know we've got colleagues in the UK in the room. You'll have to tell me if you agree with me or not over coffee, but I think it is now many orders of magnitude easier to get a passport, to renew your car tax, or to register a birth. Everything goes through a single system. And they started with a single overriding principle that drove every decision they made, which is start with user needs. For too long, we have expected users to be subservient to technology, not technology be subservient to users. I think I'm quite easy to work with. Thankfully, none of my colleagues are in the room to disagree with me. But one of the things that I know I can be difficult about is insisting that my teams spend time with clinical teams every single week, 4 hours, watching them use our systems. Not in meetings with them, not in workshops with them, but on the wards, in theatres, and in clinics. This simple but fundamental thing changes everything about what gets built. When you've stood for hours watching somebody navigate through 8 clicks to do something they need to do 50 times a day, you design differently. When you've seen the frustration of a junior doctor trying to find crucial information spread across multiple systems to look after a poorly patient at 3 a.m., you build differently. With permission of both the oncologist and the patient, I was sat recently in an oncology clinic. Having chatted with the patient beforehand, she relayed the fact that she had 2 young children exactly the same age as mine. And in that room, as the oncologist was delivering the news that that patient had a brain tumor, I sat there and watched that moment where all of his attention, all of his compassion, all of his cognitive ability should have been focused on that patient. And I saw him struggle to open the correspondence from the referring hospital, struggle to pull up the scans and how they changed over the last 6 months. You only have to do that once for it to change everything about the way you work. And we're seeing the impact of putting clinical users at the heart of the decision-making process. Our clinical teams aren't just consultees in our new electronic patient record implementation. They're the designers, the testers, the champions. They're running the sessions, they're making the decisions, they're shaping the workflows. That results in people actively chasing us for the technology, pushing us to go faster, and more importantly, staff telling us, finally, you're listening. I think the next important shift is in how we record care. I think we're in danger of the position where documentation has become a kind of proxy for care. I've documented me caring, therefore I must have cared. When often documentation is anything but. Let's think about what we're asking colleagues across Europe to do this morning. Let's think about what's happening in theatres right now. We have staff manually recording when a patient was sent for, when they arrived, when the anesthesia started, what drugs they used, when timeout was completed, when the procedure began, and when the procedure ended. Each of these are actions that should and could automatically create their own digital footprint. The act of sending for a patient should create the record, moving them should update their location, delivering care should document itself. We're starting to see aspects of this change. In our emergency department at the Leicester Royal Infirmary, observations now flow automatically from monitors into our electronic patient record. No transcription, no delay, no opportunity for human error. Time created to allow people to do the job they thought they were coming to do, and teams are happier because of it. When we started, there was some nervousness about the decision-making process. Does writing down the obs make me think about the patient more? And our finding is that it's not taken away any aspect of professional judgment. Instead, it's given time and space for people to do it. And the third kind of crucial shift I think we need to make is making data work for people delivering care, not just for management reports. There was a landmark report from the NHS called Data Saves Lives. And it's true. The more access we give to people directly involved in the care of their patients, about their patients, the easier it is to understand where we can improve. Digitizing healthcare processes allow for unprecedented tracking and analysis of clinical interventions. Unlike traditional paper-based methods, digital systems can provide real-time data on patient outcomes, medication administration, and adherence to clinical guidelines. This wealth of information itself creates a robust platform for safety improvements. And moreover, the data collected through digital systems can feed into artificial intelligence algorithms, enabling the identification of patterns and potential risks that might be invisible to the human eye. For instance, we're seeing in the US already AI flagging unusual trends in patients' vital signs or medication interactions, alerting clinicians before they become critical. We are in the foothills of what's possible. And we're starting to use AI and automation to reduce the burden on our teams. But the key is we're doing this with our clinical teams and not to them. Every automation, every algorithm is designed to augment and support clinical decision-making, not replace it. There's a breakthrough that comes when teams can understand and use their own data, not for reports, not for targets, but for improving care. when patterns emerge that help prevent readmissions, when trends show where we can intervene earlier, when data helps us to predict and prevent rather than just record and report. This means that we have to democratize the access to data and data skills. We often think knowledge is power. In our health system, and maybe also in yours, the reality is data is power. Giving people the skills and access to the data democratizes everybody's role in improving safety. So where do we start? Where do we begin on making progress on these three principles? Well, the first thing is to get the basics right. When I took on this role 12 weeks ago, having come from a different trust, a senior nurse told me something that I will never forget. She said, "I don't need artificial intelligence, Will. I need my computer to log in less than 10 minutes. I need the system not to crash when I'm documenting medication. And when I phone the help desk, I want something entirely novel. I want help." And she was absolutely right. So in both our hospital groups, we're starting with the basics. Moving to modern, reliable infrastructure, investing in devices that work, and creating a single help desk that focuses on going to people and helping them. And finally, and perhaps most importantly, making passwords manageable. But here's what's interesting about what we're starting to see. As we get these basics right, something has started to happen. The teams start to trust us again. They begin to believe that maybe, just maybe, digital really could make things better and safer. A deputy medical director at one of our sites, when I started, said to me, "Will, I've given up hope that digital will make anything better. Please just don't make it worse." I think we're starting to turn him around. And this brings us to perhaps the most crucial element. We need to put clinicians in charge of digital transformation. In both our trusts, we're creating clinical digital teams of doctors and nurses and other healthcare professionals who understand both the clinical and digital worlds. They're not just implementing systems, they're reimagining how care could be delivered in a digital age. We have tried to find across both organizations the grumpiest set of clinicians that we can. They check our work and approve every one of our systems that go live. We know if we as a team can win them, then it's ready for others. And the centrality of the clinical voice matters perhaps even more when we think about emerging technology. At the moment, we think of technology and our approach to it as the way we store and join up information. We focused on this. But this next phase of technology goes beyond storing and recording information and actually does thinking and helping. We've seen two really good examples of how we're using this new technology to help clinicians in our own organization. We have worked with an AI company to ingest all of our open-sourced clinical guideline documentations, and now they are available to ask questions of in natural language and receive an answer back in natural language. So if you were to ask our AI, "I have a patient who has diabetes, he's a male, 75 kilograms, what is the right prescription regime?" The AI will come back with that information in natural language, and then crucially, with a reference to where it found the information for you so you can check it yourself. We've also seen AI play a really important role in generating accurate and usable discharge summaries. We've piloted it in 3 wards to date, saving on average 5 hours of clinical time per junior doctor shift. And we've also used it to effectively automate our back office processes. The more we can use technology to release resources to the front line, the better. But it's not without its risks and challenges. We can't see all that AI does. When we were at first generation automation, it was relatively straightforward. You would set out the rules that you wanted the machine to follow, and you could track the path of every decision the machine made. With the next generation of AI, that isn't possible. And even the same input will yield different results. We have to be incredibly careful. But we have to embrace it as the next generation already are. I spend a significant amount of my time talking with junior doctor colleagues and nursing colleagues that have already inadvertently been using AI to help with clinical care. I have to remind them that we can't yet safely use it because we don't fully understand it. But if we don't catch up, it will be used. This is our opportunity to embrace it. So I'm imagining a future where clinical systems anticipate needs rather than create barriers. Documentation happens naturally as care is delivered. Data serves the people delivering care, not just those measuring it. And clinicians shape the digital future of healthcare. This isn't a utopian vision. Largely, we have the technology. Largely, we have the expertise. And we have the commitment from our clinical colleagues. What we need now is the courage to admit what isn't working and the determination to fix it. Because ultimately, technology and patient safety isn't about the technology. It's about giving back time to care. It's about letting our colleagues be clinicians. It's about making technology serve healthcare and not the other way around. And if we get this right, it makes all of us safer. Thank you.